Regarding the capitellum fractures, most common in females due to greater carrying angle and ability to hyperextend, a high rate of elbow stiffness, Muri classification. Type 1 is large piece. It's called Steven-Lenthal fragment. Type 2 is shear piece called Cocker-Lorentz fragment. Type 3 is comminuted, Broberg and Murray fracture. Type 4 is corner fracture. Non-displaced and minimally displaced fractures can be treated non-operatively. Consideration for CT scan should be done to identify the condition of the fracture. Consider ORIF if fracture fragments are sufficiently large. Consider total elbow arthroplasty in unreconstructible fractures. Lateral approach, mini fragment screws, anterior to posterior, countersink, use 2 screws for large fragments. Problems are AVN, blood supply, elbow stiffness, and non-union. Anterolateral approach is treatment for capitellum fracture, excision of proximal radius tumor, drainage of joint, and total elbow replacement. Anterolateral approach, landmark is brachioradialis and bicep tendon. Incision 5 cm above the flexor tendon crease over the lateral border of the bicep. Follow the muscle laterally, curving as you cross the skin crease. Then follow the medial border of brachioradialis. Internal spleen proximally between the brachialis and brachioradialis. Distally between brachioradialis and pronator teres. Structure at risk: lateral cutaneous nerve of the forearm, radial nerve, posterior trochleus nerve, and recurrent branch of radial nerve. Cubital fissure contents are radial nerve, bicep tendon, brachial artery, median nerve. This is from lateral to medial.